we come to the real world practice, it is not simple as we see. We describe the patient antiplatelets. Some patients have benefits such as they have decreased thrombotic complication, decreased ischemic risk. But as you prescribe antiplatelets, bleeding risk increases. But if you come to the real world, the soil is common. Patient is patient. Ischemic event occur in the patient, bleeding event, it happens in the patient, and mortality with the patient. So if we come to the antiplatelets, what we are using nowadays is aspirin. We usually prescribe with the 300 mg loading dose in the ACS, clopidogrel 300 to 600. If we are planning for the thrombolysis, we prescribe 300 mg, prasugrel 60 mg loading dose followed by 10 mg OD. Ticagrelor loading dose of 180 mg followed by 90 mg BD. And if we have to switch the antiplatelets, patient is not. First is plaque rupture. It reduces the thrombus burden and flow obstruction. So there is a decrease in the plaque rupture. It reduces the periprocessal damage during the procedure, balloon dilatation, there is arterial dissection, due to which there is a black disruption, distal embolization, and sideburn secretion. So there is a reduced periprocessal damage. This also decreases the external thrombosis. If we come to the ischemic and bleeding risk post PCI, initially post PCI ischemic risk is on the higher side for the first 30 days. Then as time passes, ischemic risk decreases. If we come to the bleeding risk, initially they are on the higher side, but after 30 days they remain static. Bleeding risk increases over the time. If we come in the for the drug treating, what are the ischemic risk factors? Diabetes, multivessel disease, patient having recurrent MI, they have complex CAD, more than 3 stents already patient, and there is aesthetic changes. Malignancy and CKD, they both increase ischemic and the bleeding risk. What are the factors which increase the bleeding risk? Oral anticoagulant, stroke, cirrhosis, anemia, age more than 75 years, and the thrombocytopenia. So what we have to do is we have to tailor the risk stratification. There are the various tools which we use in our daily clinical practice. There is DAPT score, PASI score, precise DAPT score, and the ARC bleeding criteria. In the high ischemic, what we can do is prolong the DAPT. We can prolong the P2Y2 inhibitor monotherapy. If patient is having bleeding risk, what we can do is we short the DAPT, early initiation of the P2Y2 monotherapy, and we can de-escalate. So there is should be a personalized approach to the patient. Patient who have bleeding risk, we should assess the ARC as per bleeding criteria. Then we can patient who have high bleeding risk, patient undergoing PCI, we can use the ultrashort DAPT. Same with the ischemic risk patients, patient who have the high ischemic risk, complex CAD, then who are resistant to the clopidogrel, patient with polyvascular disease, they have CAD and the pericardial disease, patient with the stroke. So what is the approach we should use for the personalized antiplatelet therapy? One is bleeding risk, second antiplatelet responsive, and third is ischemic risk. For the bleeding risk, we can use the clinical variables such as previous major bleeding, anemia, reduced platelet. Another procedure is non-radial access, beneficial use of GP2B3 inhibitor. We have other scores also. Other is most important factor for the bleeding and ischemic event is antiplatelet responsiveness. So we can check the platelet function testing. It can be high platelet activity, optimal platelet activity, or low platelet activity. So we can modify the drug according to patient's platelet function testing. We can use also the genetic test. There is a clopidogrel resistant test available, through which we can check the patient is ultra rapid metabolizer, poor metabolizer. In the poor metabolizer patients, we can give another drug, ticagrelor, prasugrel. In the ultra rapid metabolizer, we can shorten the clopidogrel. So there are some clinical variables also for the ischemic risk. Age is more than 75, patient diabetic, obesity. Procedure features is patient having multivessel disease, PCI of last patent vessels, bifurcations, PCI, and we have the school also. So this is a critical decision. So now we face one of the common issue is how to should we continue antiplatelet therapy, patient is having thrombocytopenia, should we help. So there are some guidelines due to which if we grade the thrombocytopenia in the 4 grade, if patient is having low platelet count below 1 lakh, we should avoid NSAIDs, use proton pump inhibitor. We can continue with the low dose aspirin or clopidogrel. If patient is having grade 2 thrombocytopenia less than 75,000, we continue with the low dose aspirin in the absence of other major bleeding risk factors. If patient is having grade 3 thrombocytopenia, that is below 50,000, we should withhold the single antiplatelet therapy unless major multiple cardiovascular risk factors or predisposing comorbidity are present. In the grade 4, which is less than 25,000, we should stop the antiplatelet therapy. Now we come to the in the post PCI we have discussed this. So how we manage the oral anticoagulant in the thrombocytopenia? There are some, we have to use oral anticoagulant in the venous thromboembolism, atrial fibrillation, mechanical factor. For the grade 1 and grade 2, we should continue with the single antiplatelet or oral anticoagulant. If patient is having grade 3 thrombocytopenia, if patient is having high thrombotic risk, then we can then stable thrombocytopenia expected for 2 months, we should consider low molecular weight heparin 50% reduction to it. In the grade 4 thrombocytopenia, we can stop the oral anticoagulant. Now, how do we modulate the strategy for DAPT? So there are some clinical scenarios. In example, this patient is having ACS patient on DAPT with aspirin prasugrel. So what should we do? For the de-escalation of antiplatelet therapy, we can switch the antiplatelet from prasugrel to clopidogrel. We can do the dose reduction, prasugrel from 10 mg to 5 mg, or we can discontinue one of the antiplatelet therapy. Same for the escalation of the antiplatelet therapy. If patient is having chronic stable angina, patient on DAPT with aspirin and clopidogrel, what we can do? We can switch the antiplatelet from clopidogrel to prasugrel or ticagrelor. We can increase the dose for the clopidogrel is not available, and we can add on the other drug. So, what the ESC guidelines say for the antithrombotic therapy in the ACS patient? So, following a PCI, our default DAPT regimen consists of potent P2 receptor inhibitor, prasugrel or ticagrelor recommended, and